Hello, everyone, and welcome to the Digital Health Wire show. My name is Jason Berry, and I'm the editor of Digital Health Wire and the host of the show. Today, we are joined by Dr. Ben Long, who's the director of hospital medicine at Magnolia Regional Health Center, which is an acute care community hospital in Northeast Mississippi and in Southern Tennessee. Dr. Long, it's great to have you here today.
Thanks so much for having me. Looking forward to speaking with you.
I am as well. I am as well. Dr. Long, why don't you tell the audience a little bit about your background and kind of the path that brought you to your current role at Magnolia?
Sure, I'd be glad to. So I was actually born and raised here in Corinth, Mississippi. Went to undergraduate at the University of Mississippi, where I got a degree in English literature, of all things. That took me straight on to medical school, as you'd expect, and attended the University of Mississippi Medical Center in Jackson, Mississippi. After that, I pursued training in internal medicine at the Medical University of South Carolina in Charleston. And then for the past 5 years, I've been part of the graduate medical education program here at Magnolia, where I'm an associate clinical professor of internal medicine. And most recently, for the past 2 years, as a medical director of the hospitals group.
Perfect. I have to ask, with the literature background, have there been any authors that have kind of shaped your or influenced your path in medicine?
Oh yeah, without a doubt. I'm one of those people who tries to find the larger story. I think in everything. And for me, my favorite author is without question C.S. Lewis, old
Mm,
British author, and his commentary on the human condition and his ability to turn an illustration, I think is timeless and universally applicable.
nice, beautiful. What's a C.S. Lewis book that, not to linger too much on the literature, not on the healthcare, but what's a C.S. Lewis book that's a favorite of yours?
Oh man, see, you throw me a curveball.
I'm throwing you curveballs right out
I
the gate here.
did not have time to prepare this, and choosing from the list. I think is the most challenging. Probably the Four Loves
Mm,
is so his deep dive exploration into again every facet of human relation
mhm.
is so universally applicable. And if you think about the English language, we have this one word, love,
Right.
that has so many different meanings, and we use it in different contexts readily. And to those of us speaking the English language, that's become somewhat intuitive, but it doesn't come anywhere close to unpacking, just how rich and deep and dynamic, that word and all its meanings are. And so he does a great job of categorizing, characterizing, and unpacking that for the reader.
Man, that's beautiful. We are off to the races here.
Uh,
Okay. Well, we can interrupt our literature conversation with a little bit of drier healthcare talk here. Why don't why don't you give us some insight into what your day-to-day looks like as the director of hospital medicine at Magnolia?
yeah. So, overall, as the medical director of hospital medicine here, my role includes just the design and optimization of our service line in the hospital, and also the oversight. I'm responsible for, the usual things like, our scope of practice, ensuring that that's, defined and appropriately implemented, that we have an appropriate staffing matrix and we keep up with that. And that would include everything like, recruitment and retention as well. And then finally, just the overall uh, uh, maintaining of the quality metrics that ensure that our purpose and goals as a group align with in the system that we serve.
I'm sure you have a wide range of metrics that you're looking at on a daily basis. What are some of the North Star metrics that you use to kind of guide your decision making and keep your finger on the pulse of the efficiency, the health of your system?
Yeah, I will borrow from the IHI, or the Institute of Healthcare Improvements, triple aim uh, illustration here, when that's, reducing overall cost of care coupled with good population health and also the experience of care for the
Mhm.
patient. So that's kind of all encompassing, I think, of uh, you know the metrics that we follow. You can rattle off many of the usual suspects, like mortality, readmission reduction, etc. But those things all fit within, nicely within that triple aim packaging of saying, the patient's experience of care and the provider's experience of care, reducing costs, operating efficiently and effectively, and then of course achieving better population health along the way. That is what we're striving towards.
Not to kind of put the cart in front of the horse for what technology you're using to enable better care, but when you're looking at solutions that might be able to help you address one of those triple aims, is the data flowing from the solution to you? Is that like a prerequisite that like we need to be able to track what this solution is doing along the lines of these three goals that we're trying to address? Is that something that you look at before you pilot a solution, before you implement it?
I think in keeping with creating a thorough enough aim statement. I think it's really important to have the goals made clear at the beginning, and then ensure that your intervention is aligning with the larger picture of what you're trying to achieve. Because as anybody who's involved in any type of quality improvement efforts knows, it's really really easy for you to go pretty far down the road and then to look up and go, I'm not even really sure what we set off to do in the first place, and are we accomplishing that? And so it's always good to have sort of that touchstone of really having a good proof statement, or a good clearly defined aim of saying, what are we trying to achieve? How will we know then if we're achieving that?
Right. Well put. Well put. Is so kind of to put the cart back behind the horse, if you will. I'm not sure if that one is a it's a real turn of phrase there, but how is Magnolia using technology to address those three aims that you just the triple aim, if you will?
So I think that this answer requires a little bit of background. So I'll take you back to 2020, when I was first tasked with just helping lead efforts to reduce pneumonia readmissions,
Mm,
which in the total sum of our pay for performance programs as a hospital, this was what was impacting us the most. We were not performing very well for our pneumonia readmissions. That was right about the time that the pandemic was, really, reaching peak, and everything just sort of changed, right? And um, about that time, the FCC, through the CARES Act, started awarding grants to help accelerate the implementation of telehealth, and we got awarded one of those grants,
mm,
around about $500,000 actually, um, in order to provide a greater range of services to our patients. So things like uh, creating access for urgent care visits virtually, and also telemedicine for outpatient care, and internet-based medical monitoring equipment.
mm,
So what I learned in diving into why were our patients with pneumonia being readmitted to the hospital within 30 days was that very few, if any, were actually coming back into the hospital due to failure of treatment of the pneumonia itself. But most of these people were coming back in because they had congestive heart failure as a comorbidity, and they were coming back in with a congestive heart failure exacerbation, which you know actually was a close second in
mhm.
terms of management that wasn't going as well as we would hope it would.
When you get that grant and you have these goals and these very haptic problems that you're looking to address, you have this huge opportunity set of solutions out there
Mm-hmm.
that you can pursue. How do you even start thinking about narrowing that down?
Yeah, so and it comes back to the simple concept of asking what is it that you hope to achieve? What's the goal? And I'll plug that into a concept in clinical care, which is the illustration of what's the difference between management and treatment. When we talk about treating a disease, um, what that is really simple to define. We're talking about curing a disease, so to be free from that disease all the way around. It's definitive. But management, on the other hand, is really not aimed at curing at all. So to the individual with heart disease, the only curative treatment would be something like a heart transplant, which is not widely practical or available at this point in time. So when we talk about treating those patients, we use these terms interchangeably all the time. Really, what we mean is we need to manage this person. So to minimize the progression of complications manifesting from that disease without really curing the underlying problem. So that therein lies the complexity of CHF management. It takes this multifaceted approach involving patient education, optimizing medication administration, and then decreasing exacerbations of the disease.
Mhm.
So long-winded explanation to kind of take us back to we get a grant to help us implement technology in our care for patients. Well, it occurred to me that as a hospitalist, when I'm tasked with reducing readmissions, that I'm responsible for what happens to my patients long after they've left the hospital. And that sort of represented an epiphany of sorts for us as a system, where we realized that we really need to pivot from this reactive approach to healthcare to a more proactive approach, and that's really how we framed building a digital health ecosystem within our healthcare system. And so as we were kind of learning, you know, what do we want to do and try to follow some of those, I can't remember who told me this, but look for the 5 A's of whatever project you're trying to operationalize. Is it appropriate, accessible, available, affordable, acceptable? And then somebody, our CEO here, Jim Hobson, said, "I'll add the sixth one. Is it affable?" And I thought that was all appropriate. So those were, that was sort of the framework to which we applied, the implementation of things like remote patient monitoring and our care navigation program, which is, on the whole, we were trying to think about how do we reconceptualize this patient care continuum as a continuum and not just episodic care that is really siloed and does not communicate well across the spaces.
I love that the affability was added when the 5 A's wasn't enough. Why do you think that the affability is an important component to not lose track of when you're rolling out a program like anything that you've done at Magnolia?
Yeah, I mean, I think it comes back to, being part of the aim of patient experience. And, we can get so caught up in, programs and systems thinking that we forget that this is a relational, game that we're playing. This is a team sport that is really, at the end of the day, we're fighting together, and it's hand to hand combat, kind of battling these things. And I think sometimes we just forget people and remembering that, like, hey, uh, we're all better off the more we relate to one another and stop thinking of patients as diseases and remember that they're people.
C.S. Lewis would be proud.
I
Ties
hope so.
right into the conversation on love earlier. You're really nailing it.
I hope
No,
so.
that one was a curveball too, so it wasn't premeditated. You're just shooting from the hip here.
I mean, I panicked for a second. I was like, gosh, I hope he doesn't ask me to define affable. I'm not sure I can.
I did a quick Google search to make sure I had all my ducks in a row before firing off the follow-up. Perfect. Are there any technologies that you've deployed that you've been shocked at how well they worked or surprised at the benefit that you actually saw as opposed to what you hoped for?
Yeah, no question. So the two biggest things that I've been involved with, and there's been rollouts really across our system that I haven't been a part of everything, um, have been our remote patient monitoring and also what we call population risk management. So that is a tool that through one of our partners, Dr. First, we were granted access to. Um, so we equipped our nurse navigator with both, so that we can monitor patients through the remote patient monitoring and through those the devices that can feed us back information, physiologic data. It's in vogue right now, without a doubt. But the population risk management tool is really a novel approach to medication management. And through this tool, we are able to cross-reference three really important, information streams. So insurance claims data with pharmacy fill data, prescription abandonment, and prescriber data. And when we can cross reference all those things, we can really create a visual of, is the patient adherent to their medication plan? And we can use that information in real time to better manage their care.
Mhm.
So if you're involved in the clinical space at all, you know that most of the care in our country is carried out in communities like Corinth. So, rural America, where there is a lot of independent businesses. So, independent pharmacy, independent private physician practice, or advanced practice provider, and then there's hospitals nearby, and these entities do not interact with one another. The interoperability, I think, is the buzzword, is not where we want it to be. So it gets really hard, and the who suffers from that is the patient. But as a hospitalist, this really matters to me because, uh, in the worst situations, it can take hours to fully understand what a patient is prescribed and by whom, and then what are they taking. And oftentimes, those are two totally different
Mhm.
questions that you have to contend with on each hospitalization.
Maybe to look at the flip side of the coin of what's been working here, are there any technologies that are getting a lot of hype, basically, that you think are a little ahead of their time or like are a little too far removed from the day-to-day patient care and you haven't really jumped on the bandwagon quite yet, as much as maybe a different system in different shoes, or anything that's just generally overhyped so far?
I don't know about um, if I would go so far as to say anything is overhyped. Um, I think that there's a lot of interest in this transitional care space. So if you look at the post acute care medicine, and if we call that just a potential space now, between hospital and where the patients seek their usual care. Um, in that immediate period, we know that that's a high risk period. So I feel like the industry is really booming uh, in terms of people innovating in that space and advocating that they've got the answer for this is how we do it. I know at least here we get at least one phone call, letter, uh, or otherwise just um, outreach every day that says, "Hey, we can let us do this for you," and it's all in that transitional care space.
Mm.
Let us take this off your plate, and so I think that necessity is the mother of invention, and so you know with how we're incentivized to be more cost efficient, with things like the Readmission Reduction Act, et cetera. Um, People are trying to figure out how to really do that well. And I think we had about 10 years where they were looking at the usual strategies and going, nothing's really emerging as the lead here. So, there's a few things that, again, we implemented remote patient monitoring with the dollars that we got from this grant, and I think that we were very eager for that to be the answer to all of our problems, and it hasn't been, and I don't know that that's because remote patient monitoring is overhyped or even that we overhyped it necessarily, so much as it is you have to really understand your needs at the local level, um, and you have to pick the right intervention that will generate proportional engagement in your medical community for it to be effective.
Dr. Long, I have to say, you are providing a great behind the scenes look at your thought process of like what are you weighing when you're looking at these solutions? What should vendors be thinking about when they're approaching you? What priorities should they keep in mind? I really appreciate you taking the time to kind of impart all this upon us here.
Thanks.
Maybe as a final wrap up here, is there a view that you've changed your mind on recently as it relates to either acute care or the healthcare industry at large? Is there a view that you've reshaped your opinion on in recent memory?
I think that when it comes to care delivery, it's the realization that different is not bad or different is not always wrong. But don't mishear me. I'm a huge proponent for standardization of care, but I think when it comes to the system and or what context your healthcare system is in, um, different most of the time is just different, and there are different ways of doing things um, that can be difficult to adjust to, but I think it takes time to understand your context and to realize that what's right for one place, for one setting, for one community, or even for a population, is not right for the other. And coming out of training, I think that's especially difficult, especially if you leave the nest, so to speak, and go into a completely different system. You get exposed, and it's very hard to discern, um, are things better, are they worse, or are they just different, or right, wrong, different. You take my
Right.
meaning.
And with different populations, different patients, if your care looks the exact same as a completely different patient population with different needs, there's something to be said that standardized, it's not better. Different is better. And that's a lot of the times there. So
Yeah, yeah.
completely agreed again. Dr. Long, this has been a fantastic conversation. I've really enjoyed speaking with you today, catching up on my literature knowledge. Appreciate you taking the time and coming on and blessing us with all your insight on these topics.
Well, listen, I really appreciate the opportunity. Yeah, I'm thankful for the platform. I really hope that it shines through that it means a lot to me. The work that's being done, the community, and the support that I receive here, and so um, yeah, just I think there's a story worth telling here, and I'm humbled that I get to be a part of that.
Right back at you too. This has been a fantastic conversation. I learned a lot. I'm sure the audience did too. Thanks everyone for watching. This has been the Digital Health Wire Show, and we'll see you next time.